Good evening, and welcome to our presentation this evening entitled New and Emerging Biologic Agents in Chronic Rhinosinusitis with Nasal Polyps, or CRS with NP, Pathophysiology Insights and Patient Selection Criteria. My name is Tara Carr. I'm an Associate Professor of Medicine at the Asthma and Airway Disease Research Center and University of Arizona in Tucson. My disclosures are listed here. I function as an advisor, consultant, reviewer, and disease speaker for multiple companies. The learning objectives for this evening are 1, to review the pathophysiologic and immunogenic molecular drivers of chronic rhinosinusitis that lead to the inflammatory endotypes and relevant comorbidities frequently observed in patients with CRS and nasal polyps. We'll discuss the differences between currently approved and emerging biologic treatment options for CRS with nasal polyps using data from clinical trials and other analyses. And we'll incorporate an individualized patient-centric focus based on consensus criteria for patients with nasal polyps when recommending a biologic therapy or endoscopic sinus surgery for treatment of their disease. So we'll start with some pretest polling. Our first question is, nasal polyps generally reveal a pathogenic proliferation of which inflammatory cytokine drivers? You can see there are 4 options here on the screen. Please select one and then hit submit before your, so we can register that result. And the options are TNF alpha and interferon alpha, interferon gamma and TNF alpha, IL-1 and IL-6, IL-4, IL-5 and IL-13, or IL-12, IL-17, and IL-33. We'll give it a few more seconds. Go ahead and pick one, and we'll review all of this during the presentation. Okay, why don't we go ahead to the next question? Our next question is, while typically predominant in about half of patients with CRS without nasal polyps, which of these cells are thought to also play a role in patients with severe type 2 CRS with nasal polyps? Eosinophils, neutrophils, CD8 positive T cells, or Th1 cells? Go ahead and pick one and hit submit. Okay, wonderful. We can go to the next slide. All right. A 39-year-old woman presents with nasal polyps and a history of moderate asthma. Her blood eosinophil level is 300 cells per microliter, and her total serum IgE is 25. Which biologic would be most appropriate for this patient? Mepolizumab, Omalizumab, Rhinosinusitis, or tezepelumab? All right, wonderful. And then moving on to the next question. A 49-year-old man with severe CRS with nasal polyps is placed on a biologic for his nasal polyps. When should he first be reassessed for response to treatment per the Euphoria Guidelines and the multidisciplinary consensus algorithm? Should he be reassessed anytime within the first 6 months, at 6 months, between 6 and 9 months, or anytime after 1 year? Great, thank you so much. And then next question. Okay. A 53-year-old man with severe CRS with nasal polyps presents for follow-up after 12 months on biologic therapy. Prior to starting the biologic, he underwent endoscopic sinus surgery twice with nasal polyp recurrence within 6 months each time. He currently shows inadequate response to the biologic per the Euphoria criteria and will not consider another surgery. What would be the most appropriate recommendation for this patient based on the Euphoria guidelines? Should he switch to a different biologic, continue the biologic for another 3 months, consider fluticasone intranasal spray, or stop the biologic and go back to medical management? Okay, thank you so much for your answers. That's the end of the pretest polling. Now we'll move on to the educational part, and we can see if we learned everything we needed to answer the post-test polls. So first, we'll overview chronic rhinosinusitis, or CRS, and chronic rhinosinusitis with nasal polyps, which is a subtype of CRS. So chronic rhinosinusitis is remarkably common in the United States. About 29 million Americans have been diagnosed with chronic rhinosinusitis, which accounts for about 11 to 12% of the total population of the US. 20% of these individuals have the nasal polyp subtype, and these are a little bit more predominantly male. The 80% have what's called non-polyp chronic rhinosinusitis, and this is a little bit more female. Those of you who treat patients who have chronic rhinosinusitis, particularly those with nasal polyps, recognize that there are significant symptoms and impact on health-related quality of life for these individuals. The cardinal symptoms of patients with chronic rhinosinusitis are a blocked nose, so they feel obstructed or congested. They can have drainage from the nose and feel it going down the back as postnasal drip. Classically, they lose their sense of smell or have reduced sense of smell related to the nasal polyps, and often sense facial pain and pressure. Patients who have CRS with nasal polyps have impaired sleep quality. They feel more tired during the day and are unable to focus, and so they're losing productivity at work and at school. And the inability to smell can lead to a loss of confidence and embarrassment for patients. On the bottom here, you can see some images on the left of a CT scan comparing a control subject with clear sinuses. You can see black air-filled sinus cavities. And on the right, there's a severe CRS with nasal polyp who has thickening of the paranasal sinuses or complete opacification of the paranasal sinuses throughout, with blockage and masses filling the nose, which is suggestive of the nasal polyps. And on the right, an endoscopic view of a normal middle turbinate and a middle turbinate with nasal polyps next to it. So how do we diagnose chronic rhinosinusitis? Well, we like to see symptoms for at least 12 weeks, and we like to see at least 2 of these symptoms clinically supported by objective criteria. The symptoms could be that mucopurulent drainage coming out the front or the back, nasal congestion or obstruction, facial pain, pressure, or fullness, and a decreased sense of smell. And then objective criteria include endoscopy to see that there's drainage coming out of the osteomeata, or if there are polyps present, or a sinus CT scan to document inflammation of those paranasal sinuses. The standard of care medical management has a few options. The first line therapy is considered to be the intranasal corticosteroids. These are topical anti-inflammatory steroids that do not have significant systemic involvement. They tend to be well tolerated. They stay at the front of the nose mostly and can have limited benefit for treatment of nasal polyps. Nasal saline irrigation is the high volume irrigation of salt water essentially into one side of the nose and out the other. There's very low risk to this irrigation. It can help to flush out extra mucus and reduce antigen load in the nasal cavities and sinus cavities. But for some patients who have lots of polyps that are blocking their nose, it's hard for the saline to actually move in and out of their nasal cavity. Nasal steroid irrigation comprises adding steroid to the nasal saline irrigation, which can have improved penetration throughout the sinus cavity and absorption over the intranasal steroids or saline alone. Oral corticosteroids can be prescribed, and they're very effective for rapidly relieving that sense of severe blockage, as well as to some extent anosmia. It's the oldest and most widely used anti-inflammatory therapy, but as we know, there are some side effects associated with systemic corticosteroid use, including potentially immune suppression, increased risk of fractures from loss of bone density, increased risk of cardiovascular disease, type 2 diabetes, and weight gain. We could also consider managing chronic sinusitis with nasal polyps with surgery or other devices. Endoscopic sinus surgery is the name given to the surgery where they go in through the holes of the nose and open up the sinus drainage tracts. providing ability to debride the sinus cavities, remove the polyps. This provides instant relief from that sense of obstruction. But patients who undergo sinus surgery are required to not only undergo that surgery, but should be using medications after the surgery to prevent regrowth of polyps. There's an intranasal steroid option called the exhalation delivery system with fluticasone, which delivers fluticasone, an anti-inflammatory steroid, throughout the sinus cavity, including to the posterior sinus cavity. This seems to have good efficacy eliminating or shrinking polyps compared with placebo, and may be more effective than the regular sprays. And then finally, steroid-eluting implantable stents can be put in either after a sinus surgery or potentially instead of a sinus surgery to deliver local steroid to the area, hopefully relieving some inflammation and reducing symptoms. So for a lot of patients, this is what their treatment plan looks like. They're recommended to use intranasal corticosteroids with saline irrigation regularly. They're given short-term bursts of oral corticosteroids to help relieve their polyps and relieve their anosmia. But about 46% of patients who have nasal polyps will ultimately go to surgery because this medical management is just not sufficient to control their symptoms. However, surgery itself is not necessarily curative. You can see here data from this Galen cohort that nasal polyps come back for about a third of patients at 6 months, 40% of patients at 18 months, and a third of patients might require repeat surgery over the next 12 years. 20% of patients actually require multiple revision surgeries to treat their sinuses. So you can see that this medical and surgical management standard of care, while it can be very helpful for patients, doesn't necessarily provide a cure or a long-term management solution for most patients. So now we'll switch over to talking about inflammation and immunologic drivers that contribute to the pathophysiology of CRS with nasal polyps. So this is a comparison of a normal epithelial response to damage and the epithelial response to damage in chronic rhinosinusitis. So on the left, you can see what a healthy sinus and nasal epithelium would look like. The red areas show injury that could be due to trauma, chemical, or pathogen, where the cells don't have normal integrity, they're separated, they're damaged. And then as the cells heal, you have what's called the epithelial mesenchymal transition. They can come together, they can proliferate, reaggregate, reestablish those cell connections, reform and regain the healthy structure of the epithelium, and develop cilia again so that you have normal functioning epithelium. On the right, in chronic rhinosinusitis, this healing process just doesn't happen normally. After injury due to the trauma, chemical, or pathogen, you don't have this proper cycle of reestablishment of epithelial cell structure, differentiation, and function. So this secondary repair cycle leads to cells being formed that have poor resting barrier function and abnormally or dysfunctioning cilia. So mucus will collect, inflammation will happen, and infections will be more likely. There are 3 what we call inflammatory endotypes in chronic rhinosinusitis that have been developed across the different types of chronic sinusitis. This what we call type 2 inflammation is the same type 2 inflammation that you hear about in other diseases like asthma. There are both type 2 helper T cells and innate lymphoid cells that secrete type 2 cytokines like IL-4, IL-5, and IL-13. You can have alternatively activated macrophages, eosinophils, and basophils involved. And then mast cells can find themselves at the center of this process related to IgE. People with type 2 inflammation commonly have nasal polyps, can also have comorbid asthma. And these patients are less likely to have cough, pus, and rhinorrhea. The non-type 2, which used to be called type 1, but is a little bit more complex than that, are the helper type 1 cells, the type 1 innate lymphoid cells, natural killer cells, CD8 cells, normal macrophages. This is part of what you would expect in a normal infection response. release of interferon gamma and IL-12 drive this infection process. And patients who have this type of inflammation are more likely to see purulent nasal discharge, such as in that non-polypoid chronic rhinosinusitis. And then finally, there's this type 3 or secondary non-type 2 subset of cellular inflammation in which neutrophils are very predominant. We think this is being driven by Th17 cells and type 3 innate lymphoid cells releasing IL-17 and IL-22 to drive some of this neutrophilic inflammation. This can also contribute to the purulent nasal discharge of both nasal polyp and non-polyp sinusitis. So this slide is showing how this all comes together to contribute to disease in nasal polyposis. On the left, you can see that epithelial barrier, which we already talked about as not healing properly to restore normal function after a trauma such as an infection. And that non-healed, not normal epithelium can have colonization of bacteria, but it also can be just easily stimulated to release chemicals like the alarmins, TSLP, IL-25, and IL-33 that induce and drive this type 2 inflammatory cascade. On the top, for people who have significant environmental allergy or specific IgE to either extrinsic or intrinsic, like Staph aureus exposures, IL-4 and IL-13 that are released by those type 2 cells induce B cell isotype switching. The B cells release IgEs. The IgEs can sit on the surface of mast cells and basophils and can degranulate those cells upon repeated exposure. Mast cells can release lots of pro-inflammatory chemicals that further potentiate that local inflammation. The IL-5 released by type 2 cells recruits eosinophils, allows eosinophils to be more active and to survive longer within the tissue. And within the tissue, they can release chemicals and also contribute to inflammation. And then finally, the IL-13 at the bottom, which is released by these type 2 cells, is thought to drive some additional epithelial effects and remodeling, such as mucus production, hyperplasia of those goblet cells, and fibroblast-induced collagen production, fibrosis, and potentially that mass effect that we see with the polyps growing and growing over time. While we love to talk about these different subtypes of disease, we recognize, of course, that there will be overlap for some of our patients. So more recent evidence is, and more work is being done in the medical field and among our scientific community to understand chronic rhinosinusitis. And while 50% of those patients without nasal polyps show some type 2 inflammation, about a quarter of those polyp patients have both type 2 and non-type 2 inflammation, so mixed inflammation. Meaning that eosinophils are not exclusive to nasal polyp disease. They can also be found in non-polyp inflammation. Neutrophils are predominant in the non-polyp disease, but can also be found in polypoid disease. So certainly this is not clear-cut, but we do understand that this is a complex inflammatory situation that will require that same degree of study. Here is a potentially more complicated picture showing how the neutrophilic and eosinophilic inflammation can be driven in the sinuses and how they really together can contribute to and potentiate each kind of inflammation. On the left, you can see the eosinophils that are responding to the infection of Staph aureus through release of these extracellular eosinophil traps, which are kind of cool. They're like shot out by the eosinophils. Charcolating crystals can be deposited, which are a result of crystallization of the granules from the eosinophils. Those are meant to fight the infection. On the right, you can see that the neutrophils also have their neutrophil extracellular traps that are shot out in response to the infections. And neutrophils also can release other chemicals, cytokines that contribute to a type 2 response, but also recruit other eosinophils and induce tissue remodeling and damage. Okay, so we're going to try to frame some of our clinical discussion through a couple of case studies. And so I'll introduce the first case to you here. And this may be familiar to you. Those of you who treat nasal polyps or chronic sinusitis will recognize some of these features in the patients that you see. So Angela is 41 years old. She was diagnosed with nasal polyps 2 years ago, and she underwent endoscopic sinus surgery 1 year ago, but her nasal polyps have since returned. She's undergone some evaluation, including allergy skin testing, which was negative. She does have asthma, which was diagnosed when she was 25 years old. She has 600 eosinophils per microliter in her blood. Her total IgE level is 25, and her FEV1 is 70%. In this case, I think you can get a sense that this is a patient who has both asthma and nasal polyps, not a lot of allergy, some evidence of eosinophils, and she's had regrowth of polyps after surgery just 1 year ago. And so she's really seen some limitations of the surgical standard of care. And as we said before, nasal polyp recurrence is quite common after surgery, particularly in people who aren't using regular intranasal corticosteroids, but can happen even in those patients who are very regularly using steroids. At a third of patients within 6 months and 40% by 18 months. So unfortunately, Angela's situation is not uncommon. Our case study number 2 is Jason. This is a 50-year-old man who was diagnosed with nasal polyps 4 years ago. And he does have environmental allergies. He had perennial allergic rhinitis since childhood. He's had blood testing for allergies positive for dust mites and cat dander. He also has eosinophils, although not as high as Angela, 225 cells per microliter. His total IgE is 150. His FEV1 is 70%. And he's been using intranasal corticosteroids, and he says, you know what, they're just not working as well. And we notice that his polyps are increasing, and they're really affecting his quality of life and ability to function. He tried saline irrigation, but hasn't been able to tolerate that because it increases pressure in his ears as his polyps have gotten bigger. He's been prescribed 3 bursts of oral corticosteroids and antibiotics over the past 2 years, despite using these intranasal steroids. And he says he's willing to consider anything to get rid of these nasal polyps. So this patient is a good example of the standard of care medical management failing him. The intranasal corticosteroids, as we mentioned before, don't have systemic absorption, which makes them great for long-term use if they're working, but also if they can't get into the sinus tissues where they're needed to reduce that inflammation, then they can't help him as much as we want them to. We talked about the saline irrigation. If he has really big polyps, it's going to be hard for the salt water to move through his nose. And the oral corticosteroids, while they help temporarily, over time, repeated courses of steroids can have cumulative systemic side effects. Okay, so we'll talk about the biologics, which are really immunogenic-based interventions. This is the next step in the future of where we're going for a lot of allergic inflammatory diseases. There are 3 biologics approved by the FDA currently for treatment of CRS with nasal polyps. And these are listed in the order in which they were FDA approved. Dupilumab is an anti-IL-4 receptor alpha antagonist that blocks signaling through both IL-4 and IL-13 receptors. This was approved in June of 2019 as add-on maintenance for adults with uncontrolled nasal polyps. It's administered as a subcutaneous injection, 300 milligrams every 2 weeks. And there were 2 phase 3 trials, which we'll review in a minute, that supported the use of this medication for nasal polyps. Omalizumab is an anti-IgE antibody, which was approved in December of 2020 for nasal polyps. This is approved for add-on maintenance for adults with inadequate response to intranasal corticosteroids for their nasal polyps. The dosing of omalizumab is based on serum IgE level and total body weight, and the dosing can be between 75 and 600 milligrams every 2 to 4 weeks. There are dosing calculators and dosing charts available widely on the internet. And their phase 3 trials were called Polyp 1 and Polyp 2. And then finally, mepolizumab is an anti-IL-5 antibody. Remember, IL-5 drives eosinophil recruitment and activation. And this was approved in July of 2021 for treatment of nasal polyps as add-on maintenance for adults with inadequate response to topical steroids. This is dosed 100 milligrams subcutaneously every 4 weeks, and the phase 3 trial was called Synapse. So we'll look at a little bit of this data. This shows the efficacy data for dupilumab with their main endpoints, which is the nasal polyp score, which is how big the polyps are, and the nasal congestion or obstruction score, which is how the patient feels their nose is working. So these show the change from baseline of each of the nasal polyp score and the nasal congestion or obstruction score for both the Sinus 24 study and the Sinus 52 study. The Sinus 24 gave either placebo or treatment for 24 weeks. After that time, they took people off treatment and monitored what happened after they came off therapy. In Sinus 52, it was randomized to either treatment or placebo and continued on that for 52 weeks. So you can see here that the nasal polyp score of patients who were on treatment on dupilumab for both the Sinus 24 and the Sinus 52, the nasal polyp score went down, which means that the polyps were shrinking. And this went down by about 2 points, which if you're not familiar with nasal polyp staging, essentially means that they shrink substantially. And you can see that once patients are off treatment, their polyps start to come back or start to get bigger, at least after that 24 weeks of therapy. Similarly, the nasal congestion scores improve over time with treatment and seem to worsen over time once the treatment is discontinued. One of the outcomes that were of interest, I think both to patients and to physicians, but were included in this study, were the reduction of the need for use of oral corticosteroids or for surgery to treat the nasal polyps. And in green, you can see that the patients who were on treatment with dupilumab over the 52-week Sinus 52, or for those who were in 24 up to 24, had just less need for surgery and for steroids. This is a summary of the safety data for those two pooled trials. You can see the total number of treatment-related adverse events in the placebo and the dupilumab groups were similar, maybe a little bit higher in the placebo group. And the most common events were listed here. Nasal polyps were seen in more patients who were on placebo. Really nothing jumps out as increased risk in the dupilumab group. Moving on to the Omalizumab data, this is both Polyp 1 and Polyp 2 data shown on the same graph. The Polyp 1 is the closed darker lines, and the Polyp 2 are the open lines. And the green is orange is the treatment group, and gray is the placebo group. And you can see here that in both Polyp 1 and Polyp 2, those individuals who were on therapy had a reduction in their polyp score. The reduction was about by 1 to 1.2 of that polyp score. And here you have the nasal congestion scores, which also improved for individuals who were on therapy as compared with those on placebo. You had about an improvement of -1 for those patients who were on therapy, which also means that they're getting better, or they're feeling better, I should say. Here we see the Omalizumab safety in the Polyp 1 and Polyp 2 groups. Again, the total number of treatment-related adverse events were similar in both groups. I think you can kind of scroll your eyes down this list and see that asthma exacerbation was more common in the patients who were on placebo as compared with Omalizumab. Similarly, nasopharyngitis was more common in placebo compared with Omalizumab, and headache was a little bit more common in the Omalizumab. And then the third drug, mepolizumab. So on the left side, you'll see the nasal polyp scores, and on the right, you'll see the nasal obstruction scores. So this is shown a little bit differently than the previous two studies. On the bottom in gray shows change for the individuals who are on placebo, or the proportion of individuals on placebo. And on the top in blue are the proportion of individuals who are on treatment. And it shows you proportions for each level of improvement or worsening. So on the left-hand side in the nasal polyp score change, you can see that 27% of individuals who were on drug had no change in their nasal polyp score. 41% of patients who were on placebo had no change in their nasal polyp score. And as we look to the 1-point improvement, 2-point improvement, 3-point improvement, 4-point improvement, we can see that the individuals who were getting treatment with mepolizumab were the ones who were having that 2, 3, 4, 5-point improvement in their polyp scores as compared with individuals who are on placebo who didn't have that level of improvement. On the right, shown in a similar way with the nasal obstruction, worsening of nasal obstruction, no change in nasal obstruction, and then improvement in the nasal obstruction scores. And that those individuals who were on mepolizumab were more likely to have a greater improvement in their nasal congestion scores. The mepolizumab study also showed reduced need for surgery in this group. And you can see here the blue line is lower than the gray line. And so fewer individuals needed surgery, and it took them longer to need surgery when they were on treatment as compared with placebo. And here's the mepolizumab safety data from their Synapse trial. Treatment-related adverse events a little bit higher in the mepolizumab group compared with placebo. You can scroll your eye down to compare these the differences in treatment-related adverse events. More people on placebo suffer from sinusitis and headache. Similar proportions with nasopharyngitis. There are other biologics that are in clinical trials at various stages for treatment of nasal polyps. These two biologics are currently in phase 3 clinical trials for treatment of nasal polyps. Benrolizumab is an IL-5 receptor alpha blocker. So a little bit different than the mepolizumab, which blocks the cytokine. This blocks the receptor, so it interferes with signaling there. There are 2 trials ongoing for both eosinophilic nasal polyps and severe nasal polyps, and are expected to report out at some point in the near future. Tezepelumab is an anti-thymic stromal lymphopoietin, or TSLP antibody. The Waypoint study is studying severe nasal polyps and has a couple more years till completion as well. So we have 3 great options. We have more options in the pipeline, and there are even more in phase 2 and phase 1 studies. The SNOT-22 score is a symptom score called the Sino-Nasal Outcome Test. There's 22 items of this SNOT test, which is very creatively named for patients with rhinitis symptoms. This is a validated patient-reported outcome measure. So for those clinicians who really care about how their patients are feeling and whether they are doing better on their drug, the SNOT-22 is a great thing to look at. And you can see here that SNOT-22 results were reported as secondary endpoints for all of the trials that we just talked about. For the dupilumab, you can see there is an improvement in the SNOT-22 score compared to placebo in both of their studies, from around -30 to -10. Omalizumab also showed improvement from about -20 something to -8. Mepolizumab showed improvement from -30 to -15. So all of these drugs seemed to help people feel better, which is very important. Okay, so we have extra medicines that we can use for nasal polyps. How do we start to recommend and select therapies for our patients who have nasal polyps? This can be a little bit challenging, but I hope that these 2 different methods we'll present here will give you a good idea of where to start. So this multidisciplinary management algorithm for CRS with nasal polyps that you can see published here in the International Forum of Allergy and Rhinology in 2021 came out of expert recommendations from a group of otolaryngologists and allergists across the United States. So we'll just walk through this algorithm briefly. For the majority of patients that you see who have nasal polyps, it's reasonable to discuss sinus surgery, endoscopic sinus surgery. And if you don't know all of the details, then an otolaryngologist who does sinus surgery would be happy to do that for you. So for people who haven't had surgery before, surgery is a good first place to start, because one of the things that it does is not only improves somebody's symptoms and debulks their polyps immediately, but it provides opening of the sinus cavities so that you can have better delivery of drugs like topical steroids and the saline irrigation into those sinus cavities to hopefully improve the function of that epithelium. So if a patient gets sinus surgery, they should be using steroid irrigations with salt water regularly, potentially intranasal corticosteroids using that EDS device, or other topical therapies as indicated. If a patient's polyps come back despite the endoscopic sinus surgery and appropriate postoperative topical steroid therapy, then there are some other things you can consider doing for that patient in combination with them using shared decision making. You could consider using a biologic therapy, particularly if there are other comorbidities that are uncontrolled for which the biologic may be useful, such as severe asthma. And then if you're going to use a biologic, you can assess response in 6 months. Some patients end up undergoing revision sinus surgery, maybe to open up the ostia a little bit more, to allow for even better delivery to the sinuses, maybe to open up the frontal sinuses or deroof the ethmoid sinuses a little bit better. Some patients who have aspirin exacerbated respiratory disease, what was previously known as Samter's triad, may benefit from aspirin desensitization as a kind of chemical therapy for reducing the inflammation in their polyps. Individuals who have had surgery or who are going for surgery can have that sinus implant, the steroid implant put in for that more local intensive anti-inflammatory therapy. And, for patients who are really suffering, you can consider a short burst of oral corticosteroids to relieve their symptoms. You can try one or all of those things. For a minority of patients, especially those who have had multiple surgeries before, who have a contraindication to surgery, who don't want to get surgery for whatever reason, or who have poorly controlled severe asthma or steroid-dependent asthma for which you're concerned they would not tolerate surgery, or for whom you would already be starting a biologic therapy, it would be reasonable to consider a biologic before the surgery and then kind of cycle through some of these other options. The Euphoria update was the European Forum for Research and Education in Allergy and Airways Diseases. In 2021, they put together an update for severe chronic rhinosinusitis and provided a couple of definitions for us. Uncontrolled sinusitis CRS with nasal polyps is that disease which is persistent or recurs despite long-term intranasal corticosteroids and has had at least one course of oral corticosteroids in the previous 2 years and or previous sino-nasal surgery. So patients who just aren't well controlled and who have disease that keeps coming back. Severe nasal polyps are big nasal polyps. So their nasal polyp score is at least 4, which is 4 out of 8. So meaning that in combination, the nasal polyps are probably at least at the middle meatus, if not bigger. And patients who are having persistent symptoms despite long-term intranasal corticosteroids. There's a website that I would encourage you to look at if you're interested, which is a combination of the American Rhinologic Society and the American College of Allergy, Asthma, and Immunology. It's a project for shared decision-making for CRS with nasal polyps. The website is listed down here. It's housed on the ACAAI website, and it's kind of a fun opportunity for patients to look at their options for CRS with nasal polyps and to communicate a little bit more informed with their physicians about what their options may be. So the Euphoria Guidelines acknowledge that our current state of medicine right now for treating nasal polyps with biologics is that we can't really predict a response in any individual patient. So the data we have are, clinical trials data, which is extremely helpful. But for any one person, we don't yet know what's the best medication and how well they'll respond. But before starting a biologic, you should confirm the diagnosis of uncontrolled severe CRS with nasal polyps. So the polyps are big. They're big despite appropriate medical or surgical management. It's reasonable to check these patients for comorbidities such as asthma or environmental allergies and consequences of those comorbidities, which might be contributing to the nasal polyps or that might influence your therapy plan. They encourage determining if type 2 inflammation is likely in these patients, where we expect that there will be type 2 inflammation in most patients who have nasal polyps. It's also, not necessarily present in everybody to the same extent. And you can look at this by using, blood eosinophils as an example. You should inform the patient about their treatment options, how your experience has been with these treatments, what the risks are of those treatments, and give them as much information as you think might be helpful for them to make an informed decision with you. And then you should decide with the patient about surgery or biologic or other interventions using that shared decision making. And then for those who have CRS and asthma, it might be useful to collaborate with an asthma specialist to choose a biologic that might be more likely to help the asthma and would maybe help the polyps at the same time. Okay. So that said, we'll go back to Angela, our first case study, who really failed the surgical standard of care. And as you remember, she's 41 years old. She's had polyps for a couple of years. Her blood tests support that she has pretty high eosinophils. She does not have allergy. And so, one question posed here is, what additional tests would you ask for? And I know you all can't really comment, but I'm not sure that I would ask for any additional tests. I think this is a patient who, has asthma and nasal polyps and eosinophilic or type 2 inflammation. Would I recommend revision surgery for this patient? Why or why not? I think I'd want to confirm that the patient had access to and was able to use regularly the good topical corticosteroids, like, in the nasal irrigations or in that EDS system. Because sometimes adding that after the polyps return can help to really reduce them enough for somebody to not need surgery right away. I also would collaborate with my otolaryngology colleagues, our rhinology specialists, who just do such a great job with revision surgeries, to see whether they felt revision surgery was going to be appropriate or helpful for this individual. Why might this patient be a good candidate for a biologic? Well, she had polyps that came back after surgery. And so, we already have seen that would be reasonable, especially if she has been using and is failing the usual topical therapies. What biologic would I recommend? Well, we have the three options. We have dupilumab, we have omalizumab, we have mepolizumab. Omalizumab is the dosing range is higher than 25. It's 30 and up. So with her IgE of 25, she technically wouldn't qualify for omalizumab dosing. So we would be picking between dupilumab and mepolizumab. I think at this point, nobody really knows which one would be better for this patient. I think both would be really good options. And you could discuss with her, what her preference would be in terms of frequency of dosing and in terms of her asthma control. And then what information would you give her to facilitate shared decision-making? I talked to her about the benefits of these drugs. I talked to her about the potential cost of all of these interventions, about the expectation for continuing medical therapy and after surgery, after revision surgery. And I'd probably send her home with a little bit of information so she could think about it before making a decision. So Jason is our 50-year-old gentleman who is using intranasal corticosteroids for a long time and has just totally had it and is struggling because his polyps are getting bigger. He's feeling worse and he wants them to go away. So what tests would I ask for? If it hasn't already been made clear by this presentation, and I'm not sure that I made it clear, blood testing doesn't really help. It's not really used right now. Biomarkers aren't really drawn in anticipation of biologic therapy. It's not part of the algorithm for starting a biologic for any of these patients. It's not part of the package insert or the FDA approved indication. So we don't have to do blood testing for patients. We don't have to do allergy testing for these patients. And so I'm not sure that I would order any additional tests for Jason. Would I recommend endoscopic sinus surgery for him? Well, I would certainly have him see my otolaryngology rhinology colleagues to talk about it. But certainly it seems that he might be a good candidate for surgery. If he hasn't had one yet, it would debulk his nose. It would open up his sinuses for better delivery of medication. and might be something that if he's willing to continue using that topical corticosteroid in his nose, might be a really good option for him. If shared decision-making reveals that he doesn't want or can't have surgery for whatever reason, then I think a biologic option would be reasonable based on those guidelines that we mentioned earlier. Which one and why? I think that would be, again, a decision to make with the patient. Euphoria Guidelines don't necessarily tell you which biologic to start, but they do recommend that after 6 months of treatment, you reassess the patient to see if they're improving. So have they seen improvement of at least one symptom or score? Sense of smell, so their smell improving. Is their nasal congestion score improving? Is their nasal polyp score improving? So are their polyps shrinking? Is their SNOT 22 getting better? Is their visual analog symptom score getting better? Are they feeling better? If they haven't had improvement in any of these scores, then the Euphoria Guidelines say, you know what? It's not working. You can consider surgery or change to another biologic drug after another round of shared decision-making with that patient. If you do see improvement in one or more of these symptoms, then determine whether that's enough for the patient. Is the patient happy with that outcome? Has their improvement been acceptable? If it has been, then you can continue with that biologic therapy and hope that with additional time, they may even see better improvement in their symptoms. If the improvement is just simply not acceptable to the patient, you can consider a short course of systemic steroids to maybe help to counteract any residual inflammation that requires that, and then reassess them. Or you can consider doing a revision surgery while they're on that biologic in hopes that the biologic would maybe prevent the polyps from growing back if they weren't able to make the polyps shrink substantially. The 6-month recommendation, I think, is accounting for the kind of slow and steady improvement that was seen in the clinical trials. People, you can start to see some differences between the treatment and the placebo group within those first couple of months. But as the month goes on, you start to see, you get to 5 or 6 months and you're seeing those groups really differentiate. So you should be able to see a significant change in those patients at 6 months. After a year of therapy, assuming the patient is, still on that treatment, if they've had a significant response, so Euphoria suggests that an adequate response includes shrinking of nasal polyps substantially, significant improvement in nasal congestion score, significant improvement in symptom score and SNOT 22 score, with no need for surgery and no need for oral corticosteroid or systemic corticosteroids. If all of those things happen, then you should continue with the biologic treatment. And if all of those things don't happen, you could consider a different biologic or consider surgery for that patient. I think these Euphoria Guidelines are great as a starting point. I'll tell you that not all of my patients really expect all of those definitions to be fulfilled for shrinking of polyps and improvement in nasal congestion score. So I'm not sure that we always have to be so strict for all of these responses to be met, but certainly it would be amazing if we could meet this adequate response for our patients who are on biologics. And, just to say it in a very clear way, that we don't have head-to-head clinical trials between the available biologics for nasal polyps. So we need to be familiar with the way each one works, with the potential risks, the potential benefits, the potential comorbid diseases that could improve with these therapies, and need to present them to patients as honestly as we can. And so just to refresh, the dupilumab is an IL-4 receptor alpha antagonist that inhibits signaling of IL-4 and IL-13, which are key drivers of type 2 inflammation, as we saw on those slides earlier. Omalizumab is an anti-IgE antibody, which prevents IgE from binding to the receptors on those mast cells and basophils, so they can't be activated by exposure to antigens and potentiating that inflammatory response. There's evidence that IgE, both to environmental allergens, but also to things like Staph aureus endotoxins, can contribute to the inflammation in the polyps. And then mepolizumab blocks IL-5, the cytokine, and inactivates it so it can't signal through the receptor. So you're not driving those eosinophils recruiting and into tissues. And so you'll reduce the eosinophils present and the inflammation subsequent to eosinophil activation. So in summary, we have understood more and more about the pathogenesis of chronic rhinosinusitis in the recent years. With introduction of biologics, we know more about how polyps form and how maybe to manage polyps better. Treatment for nasal polyps can be based on that molecular driver of inflammation, whether it's the cytokines, whether it's the IgE, but also should be altered for response to treatment and make sure that patients are involved in that therapy. And then with the new and emerging treatment options we have for nasal polyps, we're hopeful that the prevalence of recalcitrant nasal polyps will diminish over time, and the number of patients who tell you they've been suffering from this disease for 30 years will gradually reduce. So with that, I think we can jump to the post-test and complete those 5 questions again, and we'll have a minute to talk about them too. So nasal polyps generally reveal a pathogenic proliferation of which inflammatory cytokine drivers? Was it the interferon gamma TNF alpha, IL-1, IL-6, IL-4, IL-5, and IL-13, IL-12, IL-17, and IL-33? Remember to hit submit. All right. Well, thank you so much to those of you who answered the question. I'm happy to say that on the pretest, about 43% selected IL-4, 5, and 13, and all 100% of you who have answered the question selected that. And that is the answer that we were looking for and that we talked about earlier in the slides, that IL-4, IL-5, IL-13 are released by those type 2 cells, especially in nasal polyps, and drive the downstream inflammation. All right. So shall we go to the next one? Okay. Well, typically predominant in 50% of patients with CRS without nasal polyps, which of these cells are thought to also play a role in patients with severe type 2 CRS with nasal polyps? All right, great. Well, everybody who's answered has answered eosinophils, and I'm going to go ahead and say that that's the right answer. I'm reading this question carefully today and realizing it's a little bit confusing because, you know, both neutrophils and eosinophils can be present in type 2 CRS with nasal polyps, and both are you know, present in CRS without nasal polyps. I think certainly we focused a lot on eosinophilic inflammation in severe type 2 nasal polyps. And so let's take that one, but let's not forget that there are lots of neutrophils in non-polypoid sinusitis, and the neutrophils can certainly be present in severe polyps as well. All right, next slide. Okay, so our 39-year-old woman with nasal polyps, moderate asthma, blood eosinophils of 300, and total serum IgE at 25. Which biologic are we thinking would be most appropriate for this patient? Mepolizumab, omalizumab, Benrolizumab, or tezepelumab? All right, thanks, guys. So half of you on the pretest selected mepolizumab, and all of you on the post-test selected mepolizumab, and I would agree. I think that would be the most appropriate for this patient. Not only does she have evidence of eosinophilic inflammation, which is not a requirement for starting anti-eosinophil medications for nasal polyps, but she does not really meet criteria for omalizumab with a low serum IgE. And so I think mepolizumab would be a great place to start for this individual. And then, of course, Benrolizumab and tezepelumab were not discussed as currently FDA approved for treatment of polyps. Okay, next one. All right, so this is a gentleman who's on a biologic for severe nasal polyps. When should he be first reassessed for response to treatment per the Euphoria Guidelines and the multidisciplinary consensus algorithm? Anytime in the first 6 months, at 6 months, between 6 and 9 months, or anytime after a year. All right. I see most of the responses are in, and at 6 months was the correct answer, and all of you got that one. And again, I'd encourage you to bring the patient back into the clinic before that 6-month time point to see how it's going, to see if they're having trouble or any side effects of the injections, if they have concerns, make sure they're continuing to use their other medications as appropriate. So you don't have to wait 6 months to see them for the first time after starting therapy, but usually we give it 6 months to really assess them and say, is it helping or is it not? So wonderful. Next question. Okay, and then this is the 53-year-old man who's been on a biologic for 12 months for his severe nasal polyp. He's also had endoscopic sinus surgery twice. His polyps keep coming back. And clearly he has an inadequate response to the biologic. He's not going to consider another surgery. So per the Euphoria Guidelines, what are we going to do for this gentleman? Okay, great. Well, all of you have selected switch to a different biologic, and I think that would be very appropriate for this individual because the biologics work differently. You saw that they have very different mechanisms of action, and it might be that the one that he's on is just not the right one to treat his inflammation, and a different one might do better. So a different biologic is a really good idea. Okay. So congratulations. That was the end of the post-test polling. The group did very, very well. And now I'd like to encourage question and answer session. We have a few minutes left in this evening. You can enter questions, type them into the question box. I'll give a couple of minutes because I know it can take a little bit for people to open it and type them out. And I'd be happy to field whatever questions I can. I don't see any questions quite yet, but I'll give it another few seconds in case they're long questions. Okay. Thank you. Thank you. Okay. Well, thank you all so much for joining this evening. I hope that this has been informative and I hope that it's been fun. I'd like to remind you on this final slide that for additional resources and information related to CRS with nasal polyps, please visit the integrityce.com website. And at the end of this presentation, you'll be redirected to the evaluation site, so you can go ahead and evaluate it immediately, or you can claim your CME credit at this website listed here. Thank you again so much for joining us this evening. I really appreciate you attending and participating with the questions, and I hope you have